Dr. Kaylin Pierce is an assistant professor and doctoral program coordinator at Mercer University. She has worked in higher education, disability services, and other rehabilitation-focused settings, in addition to career counseling and private practice settings with predominantly disabled and queer populations. She is the founding chair of the NARACE's Accessibility Committee and regularly consults with organizations and divisions in counseling regarding accessible programming and conferences. Dr. Pierce uses a disability culture and identity focused model that is trauma informed and grounded in disability justice. As a disabled academic, her advocacy work focuses on the normalization and recognition of disability identity to support cross-disability collective liberation. Dr. Pierce, we're so honored to have you join us here today. Next, Dr. Joe Charette is an LPC in Pennsylvania and Vice President of Programs and Operations at Bethany Children's Home. Dr. Charette's experience in accessibility and counseling spaces comes from his work as a conference planner for several professional organizations and his work on the NARACE's Accessibility Committee. Dr. Charette, we're so honored to have you here joining us today as well. And last but certainly not least, Dr. Valeo Khan-Snyder is an openly—
Not a doctor yet.
Oh, sorry. Well, soon to be. Valeo Khan-Snyder is an openly queer and transgender clinical mental health counselor and is the current president-elect for the American Counseling Association of Iowa and the Accessibility Coordination Subcommittee for NCACES. Valeo is passionate about developing a strong social justice advocacy presence at the state and national level. As a disabled professional, he is passionate about advocacy, including the provision of education, building advocacy-centered communities, and reducing access barriers within our educational spaces. Dr. Pierce and Dr. Charette and Valeo, we're so honored to have all three of you join us today. And at this point, the floor is yours.
Thanks, Daniel. And thanks everybody for showing up on a Friday afternoon. I see most people have their cameras off. That's fine. If you want to turn your camera on, if you want to engage with us, that's also great. And we will be watching the chat box for questions that come in during the presentation. We also hopefully will have some time at the end for questions, as Daniel mentioned. So just a quick look at some learning objectives. Hopefully, we're going to cover each of these things. So number one is identifying physical and social barriers to accessibility and equity within educational spaces and programming. Two is focused on ableism in systems and how it impacts retention, promotion, and disability representation in counseling leadership. And then three, applying disability affirming frameworks to evaluate current advocacy efforts or to guide new initiatives. So you just heard a bit about us, but we wanted to just highlight some of the disability-related experience as well, and I'll let my colleagues lead off with anything that they want to maybe add to what you just heard from the bios that would be relevant.
I think collaboratively, the three of us have done quite a bit of work in the conference accessibility spaces, particularly within our respective regions, within North Central ACES and our ACES. Working together to ensure that we are implementing disability advocacy on multiple levels throughout that process. So the three of us have been very involved within that space and developing a framework for what those spaces can look like within our field.
Great. Go ahead, Joe.
I was just going to say nothing to add from me that we haven't covered. So.
Well, I'm going to put you on the spot. Joe and I have both done quite a bit of advocacy within our particular universities, directly with departments and also on a systemic level. So I know in my bio, it mentions that I was at Penn State's Disability Services for 4 years. I was also a liaison with a Universal Design for Learning and Teach to Reach program and some other initiatives on campus around accessibility and identifying barriers. But both of us have done a lot of that work in our faculty and administrative roles within universities.
Absolutely, and I should add to the folks just from my bio. I'm a recovering full-time academic. That's what I'll call myself. I just transitioned out of an academic space, but in my new role, which is a clinical administration role, I am responsible for facilities and operations of a residential facility. So this work also falls under my team.
Great. So that's a bit on the professional end. Let's hit possessionality because I think it's important with this topic. So I am always first to own that I am very much on an identity forward disability justice end of all of this. I identify as a disabled academic. I identify very much with community and community spaces. And so kind of hinting at what we'll discuss in a second about language, we will be using language interchangeably in terms of person first, identity first, and largely based on known preferences, our own preferences, to be reflective of ourselves. I use almost exclusively identity focused language unless I'm quoting something or it's with a group known to have person first preferences. So others?
Yep. Very much same with myself. I am a disabled mental health counselor. And I also tend to use identity first language, particularly as I'm unpacking a lot of my own internalized ableism and things through my own clinical work and my own work with my therapist and very dear friends who have supported me in that process. And so that is something that I have been owning for myself, and you will see that interchange as well for how I refer to myself and my own disability versus how I refer to experiences with other folks. I work with, as a clinician, I work with a lot of folks who have chronic, progressive, dynamic disabilities. And so the ways that we both show up in session can look very different depending on those spaces. And so as we go through and talk about personal experiences with some of these topics, talk about what some of these things can look like in different spaces, you'll see some of that interchange.
I will also use language interchangeably as a able-bodied but staunch and very active ally. I am a person who typically defaults to, because most of this comes up in clinical and classroom settings for me, default to whatever the person who might have an identified space in the community uses is typically what I'm going to default to. But as I'm speaking today, I will be using things interchangeably as well.
Awesome. And we'll do a deep dive on language in like 2-3 slides, but important to get it out of the way up front so that nobody is confused or off-put. All right, so let's talk through a few definitions, make sure we're all on the same page. This is an ARCA webinar. I'm assuming most of us are going to be on the same page because we're going to start with very basic definitions, but I think it's important to lay some groundwork. So we are using the ADA definition of disability. This is a person who has a physical or mental impairment that substantially limits one or more major life activity. Examples of those life activities, right, are outlined by the ADA and various organizations: breathing, walking, talking, hearing, sleeping, caring for oneself, also major bodily functions, so immune system, and kind of everything falls under here. It's a very broad definition. So we're looking mostly at self-identification and using this civil rights oriented definition of disability. This is what we mean when we're talking about disability in this presentation for the next hour plus that you're with us. And then this is the definition of accessibility that I have been using and that Joe and I use, and now Leo in all of the regions that we're working with for conferences, because I find it helpful. A lot of times when we start talking about accessibility, and I think you'll hear us share this throughout with our various personal examples, we ask about this, we talk about it, and then we get a lot of interesting things back where it's very clear that people did not know what we meant. So I'm consulting with an organization and literally just had a meeting yesterday where we had put some things on the feedback form around, if you had challenges with accessibility, please let us know. And we got things like, you had to sign up for sessions in advance. The sessions filled up too fast, Or I think there was yet again something about cost, because I get a lot of people where, that's affordability. That is, reducing your conference price is not in fact making it more accessible, it's making it more affordable, right? That's a different A word that you're looking for. So this definition of accessibility has been really helpful for me. It's out of a Office for Civil Rights case. So it's a case resolution definition. The citation is very odd if you go looking for it, because it's effectively case law. But this resolution defines accessibility as meaning when a person with a disability is afforded the opportunity to acquire the same information, engage in the same interactions, and enjoy the same services as a person without a disability. And here's the key: in an equally integrated and equally effective manner with substantially equivalent ease of use. Equally integrated, equally effective manner, substantially equivalent ease of use. And I can tell you that from working in disability services and having to look at a lot of these case resolutions to do our program evaluations on our policies and protocols, the vast majority of these case resolutions are not in fact just like overtly, we did not provide any access. Some of them are for sure. But a lot of them are that it was not equally integrated, it was not equally effective, or there was not substantially equivalent ease of use or access to that space. So that's the key in how we're framing it. Leah.
Yeah, I think one of the things in terms of equivalent ease of use, like, just because I have the privilege of being able to ask an able-bodied friend, so my phone a Joe, just because I'm able to ask an able-bodied friend to help me manage a task, take care of things, figure out transport to a venue for a conference or residency or work meeting, does not mean that it is necessarily accessible for me, because if I didn't have the privilege of having my Joe with me, for example, it's something that I wouldn't have been able to access. We actually ran into that a little bit at a conference last year when I was on significant lifting restrictions because of a surgery that I had had. So I had to utilize Phone a Joe a handful of times throughout the weekend.
Yeah, and I think we've all been in those situations where it's like, okay, it's fundamentally legally accessible, but it's not usable, and it's certainly not equitable. And we're going to kind of break down all of those definitions a little bit later as we get into community stuff. Joe?
Lynn, I'm so glad you brought up the affordability piece, because that's the example that was sticking in my head.
How many times have we been in meetings when that's come up, right?
Right. But and I'm glad you mentioned equity too, because that's another word that I see get used interchangeably with accessibility, but we know you can't even talk about equity unless you've already talked about accessibility. So
yeah, and what this ultimately comes down to, and we'll touch on it some other places, but at least for me, what this ultimately comes down to is this often gets co-opted, and we'll get to that as we kind of get more from a affirming standpoint. All right, can of worms, let's talk language.
Yeah. So language often gets politicized, and there are a lot of feelings about language. I, in my clinical work, am primarily a person-centered and narrative therapist, so language is very important to the clinical work that I do, which is why I decided to take on this slide. So person-first language, we noted, is commonly used in academia, largely to break down some of the stigma surrounding lived experiences with disability, and places the person before the disability. So being a person-centered counselor, identifying that this is a person with a disability, a person experiencing hearing loss, an individual with schizophrenia, a person who uses a wheelchair, etc. Putting that person first and centering the person as opposed to the disability that they experience. The counter to that is identity first language. We see this pretty commonly used in disability spaces. So the concept of identity first language is that the disability should be the descriptor. For a lot of folks who utilize identity first language, it is breaking down that stigma in a different way, saying that being disabled is not a bad thing. It is not a bad thing to identify with that disability and what that looks like. So autistic people, the deaf community, wheelchair user, blind or vision impaired. I will frequently state that I am an ambulatory wheelchair user, as opposed to a person who uses a wheelchair. And this is, again, a way to break down the way that we contextualize our disability, the way that we contextualize the disability communities that we occupy, what those spaces look like for us. So you will see these types of language used in different ways in different spaces. A lot of times we see that person first language used in academia to center the people who are experiencing the disability, to center the personhood and their experiences, versus centering the disability and the impacts of the disability on the person. And so it really just depends on the intent of the space and how that language can then shift the ways that we use those spaces. I would argue that neither of them is better or worse. They are just different ways of utilizing language to describe experiences. And different people have different preferences on how they contextualize their own experiences with disabilities. Like I stated, and like Lynn has stated, we like to use identity first language quite a bit for ourselves, while also knowing and understanding that there are some folks who prefer to use person first language for themselves. So being able to learn what those experiences look like for the folks that we are working with, for the folks that we are serving, for the folks who we are assisting with access. It can be really important to have a conversation about the way that they would like us to refer to them and their experiences with their disability personally. There are other types of disability language and some nuances surrounding language. So we'll talk a little bit about disabling language. So people who prefer person first language tend to group that identity first language in with disabling language. So saying that using that identity first, so I will use wheelchair user as an example because that's part of my lived experience. Identifying that, saying that you're a wheelchair user is disabling, it's limiting, it's, putting a small scope on what that experience is. You're a person, not just a wheelchair user. When stating that I'm a wheelchair user can actually be really empowering for me personally. So people who prefer that identity first language will tend to make a distinction between empowering identity language versus that disempowering or disabling language. So that disabling language can potentially include outdated or inaccurate terms and offensive slurs. So handicapped, wheelchair bound as opposed to wheelchair user, in order to help folks understand that we can utilize disability as an identity and find empowerment in that without it being disabling, without it being inaccurate, without it being outdated or offensive. wheelchair user tends to get labeled by folks as person first, even though it is identity first and non-disabling. So person first would actually be person who uses a wheelchair as opposed to wheelchair user. It's just a non-disabling way of stating somebody who uses a wheelchair. Yeah, it's a wheelchair user. So you can have that identity first language without it being disabling language. Some other forms of disabling language may also be slurs like crippled, or using, again, outdated terms, so schizophrenics, stigmatizing based on history of the ways that some of those words have been used against communities. So those are some things to think about in terms of disabling language or inappropriate language. In-group language can include disability-specific or assistive device-specific slang, and ways to kind of reclaim some of those negative slurs. I do know some folks who identify as crippled because that is their personal reclamation of that word that was used so often against our community as a slur. That is not to say that someone outside of the community, without knowing that that is their self-identity, can label that person as crippled and have that be okay. If they haven't had that conversation about that language beforehand. So it's really important, again, to know individual preference, individual stance on what language is used around them. There's language that is out of group, that is sometimes designed specifically to avoid saying the word disabled. Folks, disabled is not a bad word. Disabled is not a slur. We can say disabled. There's been a pretty big movement around the concept that disability is not a dirty word. So some of this language that you may have heard, differently abled, diffability, handy capable, people with different abilities.
Special needs, diverse
special
ability.
needs.
I think we could probably go on.
Right. All to avoid saying disabled. And so when we're talking about disability language, it's also really important to remember that identifying that something as a disability is not inherently bad, is not inherently a dirty word. Lynn, Joe, anything else to add on language?
No, I think I'd just say that, we spent a while on this slide, and that's somewhat by design, right? Because this is an important piece of this. And we're going to be talking a lot about the bias in higher ed and counseling, ableism, community affirming approaches. This is one of the really, really, really obvious things that community can point to and say, we have not been represented by the people who say that they are working with us. They have not been working with us, right? Because we've been having this conversation since the 80s. That person first language is not representative of many of our communities. And it's only with the last edition of APA that we even have been allowed to publish with person first language, with identity first language rather. And most of us are still putting language statements, both because it's a good practice, but also as self-defense, because if we don't, we're going to get an R&R that says, change your language, even when it's our language and should be empowered as something that we can choose and self-select. But at worst, it's just going to be rejected due to language. Joe, anything?
I just want to add something quick, especially for anyone who might be feeling discomfort around using identity first language. As a person who was like staunchly trained in using person first language, and Lynn was the first person to ever tell me that identity first language was an okay thing. And I remember
which is probably very jarring because it was me.
I was like, what do you mean by that? And I even think like my students just a couple weeks ago in the class I'm teaching watched the movie or the documentary Crip Camp, and they were all afraid to say the title because they were like, oh, it's insulting. And I was like, okay, well, let's have a conversation about the intentionality behind the language. But if you're thinking about this beautiful explanation that Leo gave of out of group language or discomfort around person first language, the thing I just want you to ask yourself is, person first language came from this place of putting the person's personhood first, and why does that have to be mutually exclusive with disability identity, right? Because disability is a lived and living experience, and there's personhood inherent in that, right? So I want you to think about that if there's discomfort there.
Yeah, we also have
Yeah.
some really good research that it doesn't do anything regarding bias, because you can change your word order and be just as offensive to me. So if anybody wants that research, contact me, because this could easily be its own like 3-hour workshop. So I'm going to move us forward, and Joe's going to run us through some history very quickly that probably a lot of us know.
Leo, were you going to add something before I continue?
Sorry, did I not say?
The only quick thing that I was going to add is, if I as a person say that I utilize, identity first language, and you don't then use that identity first language for me, that is denying my personhood and my
And it
autonomy.
happens all the time.
Mm-hmm.
So if that's something that's uncomfortable to you, just remember, like, it's that person's autonomy that you are stripping away with that discomfort.
It is also an effort to keep able-bodied people comfortable. Let's just say that. And with that, I'm going to move on to some things that you might already know.
Thanks, Joe.
Of course. So if I'm going to go through this briefly, because some of us may be familiar with some of these statistics, but in case you're not, right? The most available data that we have is that there's over 60 million Americans living with a disability. So that makes them the actual largest majority group. And among kind of, I think, social context level discussion, and specifically within counseling and counselor education, one of the least talked about minority groups, if not the absolute least talked about, for sure, at least in the spaces that the three of us have been in. And the Americans with Disabilities Act has been around for what, 20, going on 24 years now. And
30s.
24.
Your math is bad.
Again, liberal arts.
34.
34 years.
Yeah, 33,
Leo.
34. It was like within a month of my birthday. So I'm always going to know how old this act is. And nobody's called me old when I've said that yet. One of these days I'm going to be like, this was when I was born and look at me. And my students are going to be like, well, but like you're ancient. But it hasn't happened yet. So.
And as you can see here, despite 33, 34 years of existence with that act, we're still in some of the same places that the community has been in since the passage of that act. And there's been a lot of struggle and a lot of backlash to have progress made in those 30 years. It doesn't mean that the fight's not continuing, and we can talk a little bit more about retention of strong advocates and allies in that fight as a result of some of the backlash that people have experienced. And we've got plenty of examples to illustrate what we're talking about. Do either of you have specific ones that you wanted to share?
We will get there as far as I'm concerned. Leo?
Okay.
Okay. This is background.
So looking specifically at the context of higher education, and again, you folks, please jump in where you see fit. Being aware of disability as a culture, disability pride, and the current level or lack thereof of acceptance and social justice movements related to disability is essential for embodiment and active disability allyship. You have to be focused on, again, disability culture as a whole, but group identity with shared experiences, the history of oppression specific to disability spaces, the disability community, and this historical context. By the way, just like you already likely have the skills to do with every other marginalized group, it's the same idea, and we're still stuck in this same place because it's not something that gets talked about. It's not something that, so I asked my students a couple weeks ago when I had them watch Crip Camp and we were talking about disability justice and universal design and counseling, how many of them in their human services degrees had been taught about disability. And they, at least 10 of my students said this was the first time they had ever talked about it. right? That's a massive problem and is contributing to some of the issues that we're continuing to see, as well as continuing to cause harm for clients, for other counselors who are part of this community, disabled academics, right? It's part of the thing that's contributing to this lack of retention that we're seeing as well. Higher education as a system just kind of exists in conflict with disability, and that kind of necessary inclusion and belonging is rare and most oftentimes absent based on, you know, the experiences that I'm aware of. And it's something that gets like we were talking about earlier, lumped into DEI or equity conversations, but people are still not actually talking about it because either it's just not talked about or it's not understood. There's ignorance there. There is so much work that we have to be doing and could be doing. Well, Lynn, I'm hearing your voice in my head that oftentimes what we see, even in the conference spaces, right, is we've met the legal threshold for what we have to do, but nobody's thinking about what we could actually be doing. And I think that that's a perspective that Lynn shared with me that has been helpful for my journey, especially in this allyship work, but also just my journey as a professional and as a counselor and integrating this into my work. So there's a lot more we could be doing, and it's not often understood or not safe to express, right? Some of the environments that disabled counselors or disabled academics or disabled clients might be in, if they express discontent or experiences of harm with how things are going, they're often met with backlash, sometimes even threats of violence. And if any of you are saying, like, how could that happen in counseling or counselor education? It happens every day. And it's such a real and somewhat toxic experience, right? And disability is so Lynn, clarify to me what you meant here so that I don't represent it wrong. Disability is expensive.
So expensive. Time, money, emotional cost, self-advocating, all of the things. So, you know, I drive to conferences and put miles on my car and incur more costs than airline, because if I fly, there's a decent chance, and it's happened a few times in a row lately, that the airline's going to destroy my chair and I'm going to be without it for multiple months, probably incur a hospital bill to boot, right? That's one tiny example. And when everything that you do is that way, everything that you do is that way, it really, really adds up. And then there's this bias that prevents us from being able to always self-advocate, right? We'll continue to give examples, especially as we get more into the community-oriented place, but you'll notice that, you know, I had the ally set up this slide and the other one on bias, right? Because we were half joking when we were prepping for this presentation, but Joe said, you know, we've been in meetings together where it's like, we're having a conversation and everybody's like, oh, Joe's such a great ally. And then there's Lynn, and, you know, and I'm like, yeah, that's how it's perceived. There's a social cost to a lot of this, and it's really, really unsafe, and it's very isolating. So honestly, the main thing on my mind when I get to this slide all the time, since you asked, Joe, is that I felt like I needed to reinforce that disability is expensive, and using expensive in a really holistic way. And this entered my slide decks during my dissertation, my final phase of my dissertation, when I had spent several months doing data analysis, mostly while I was hooked up to IV infusions, and nobody in my program knew what was going on, because I didn't know if it was safe to tell people that that's what was going on. And it was super isolating.
Yeah. And when we talk about higher ed, when we talk about counseling and counselor ed spaces, and we think about course requirements or requirements of clients in terms of attendance, for example, hey, I might be in the hospital and not have control over that. My body might be too broken for me to travel safely. You know, I may be in so much pain that I am bedbound. And if I have a course requirement of attendance, I might not be able to meet that requirement. It's one of the reasons that I ended up going for my master's and now my doctorate through online programs, because those are significantly more accessible to me. Because even on days that I'm bedbound, I can join a Zoom call from my bed.
And
and
it's
that's what's
constant cost
accessible to me.
analysis.
In terms of client work, you know, do we have attendance requirements for clients? You know, if you miss so many sessions, you incur fees or you get dropped off a clinician's schedule, which could make our services more inaccessible to clients and other folks that we work with.
You're going to steal all of your thunder for advocacy, Leo. So I think it comes down to, if you haven't, we will. I think if you haven't read Academic Ableism, this is specifically on disability culture in higher ed, right? If you haven't read Academic Ableism and you work in higher ed, you owe it to yourself to read it. Please do. It is free through Michigan Press. There's a free audio file as well. It's the title is Academic Ableism, and the author is Dolmage, and he does a very good job of deconstructing the structural pieces of this, which it's beyond the scope of this presentation to explain exactly why higher ed has become so ableist and biased, but it is. Please believe us that it is. And really at the root of it is this piece around higher ed being in conflict with disability, because Dolmage's kind of central argument is that the somewhat artificial creation of a system of higher education has necessitated certain things being bracketed into a category of lower education, and disability has always been lower education. So it's really a structural threat to the system to allow folks with disabilities in. This is way beyond, Ed Roberts and the Rolling Quads and Berkeley in the 80s, when he applied and was told, we've tried cripples before and it doesn't work. That speaks to something very deep, and it speaks to something much more than was said, right? Face value, we've tried it, it doesn't work. The subtext is really, you're the people who are supposed to be being experimented on, not the people who are supposed to be in the seats, and certainly not behind the lectern. So there's this whole system within higher ed that you owe it to yourself to read more about, because we can't cover it all here.
I want to highlight something to leave you with, and to also echo that you should read Academic Ableism.
Please do.
Is Lynn mentioned the word please, or please believe us. This is if you really want to understand disability culture, it takes nothing of you more than just believing a person when they tell you about their experience. And if you are a counselor or you're an educator, I know you already know how to do that. Yet I'm going to use the example again from this meeting. I have sat in meetings and watched Lynn talk about her experience or the community experiences, and it's met with almost vile disdain. But if I talk about it, people are like, oh yes, it makes total sense. It's, and that is an illustration of that issue, and that has a lot to do with many privileges that I hold, but that's the problem that we're talking about. And it literally just takes believing someone when they tell you what's happening.
Yep.
Was this me too?
Me, rock, paper, scissors.
Well, you start off and I'll jump in.
Okay. So largely what Joe was speaking to, right, that when you ask people in human services if they've gotten this education, rehab students are getting this education. And outside of that, most counseling students are not. I feel really, really safe in saying that. And we use Feather and Carlson because it's one of the only things that we have, because we're not even really researching this in counselor ed yet. There's a little bit emerging, and I could name the dozen researchers working in this space off the top of my head, right? So research is really limited. Here's what we know. 36% of faculty, when surveyed, are self-reporting that they believe their program is ineffective at addressing disability topics. Only 10.6% believe that their program is very effective in the content area. And we also see a significant correlation between self-assessment of competency to teach disability and related content with previous work or personal experience with disability. And you note that nobody's really saying like, oh, my education in this is really good, right? It's I've worked with people with disability, or I know people with disability, a family member is disabled, I'm disabled, right? Whatever it is. That's often the largest thing that we're seeing with people feeling competent to work with this topic. We've got Smart and Smart reporting that we don't have sites that allow students for exposure to disability and to disabled client populations, right? We've got all kinds of problems with whether people are being exposed and appropriately trained in working with disabled clients. And this is the largest minority group. So that's a really big problem.
Well, and I think part of that too, systemically, counselors weren't able to be credentialed with Medicare until recently. A lot of folks who experience disability on a lot of different levels have Medicare as their insurance, and so counselors were not able to see and bill those clients. So unless they were able to be private pay or they had multiple insurances, that was also a systemic problem that we were seeing.
It also, if it's not integrated across our courses, and if we're not teaching people how to teach it, how do we expect them to do this, right? I talk a lot about an ableism pipeline. We have a highly ableist, highly biased society. We're going to unpack some of what we mean around ableism a little bit later as well. We don't talk about disability, right? And we've got all these other barriers that we're going to outline when we get to some of our advocacy pieces to people having appropriate exposure to disability, to be really competent and to be able to have nuanced conversations around this topic. And then we're not doing anything in our programs. And I would argue it's even hard in rehab, right? I've got 2 years to undo everything society has done, even with a focus almost exclusively on disability. And so then if they're getting it one day in a multicultural class, and I can tell you that the one day that we talked about disability in my multicultural class, advanced multicultural class at a doctoral level, was the same day that I was asked to do a privilege walk in a wheelchair on a hill. So I'm just gonna maybe leave us there unless somebody else has got something, because that's where we are. That's just where we are. So we got to do it on the back end once people are out into their classroom or into their practice space.
And I will share, folks, and I'm going to talk about this story a little bit later in the presentation, but I will tell you that I learned what I now know, or I started to learn that purely by chance and by accident, right? Because it's certainly not things I was taught in my master's program. I was taught a lot about psychiatric disability, and I'm using that language specifically because that's the way that it was framed, but I was not taught this information in a classroom.
Right. So we're gonna keep unpacking this around access. This is some of the basic stuff, though. So we're gonna do a couple of levels, and I want to be able to focus some on the really community oriented and justice oriented and affirming models. But this is bare minimum. Y'all, this is parts of this are just to not be sued, right? And other parts of this are just to be a decent human being. So is your space actually physically accessible? And do you know that? And have you used the checklist, or have you gotten appropriate consultation? Because there are lots and lots and lots of hazards that are really common in clinical spaces. And these are all outlined, right? It's not a secret. You can look at the ADA checklist and you can start to get a sense of that, but seeking consultation here is really good. If you don't have a space cleared in your waiting room for mobility devices, that's one of the common ones, right? If I love plants with nothing under them, that's a really common hazard, right? Someone who is a white cane user or blind or vision impaired, low vision, is going to run into that, right? We've got a lot of reach issues. I went to a practice for a while that had this one of those wonderful little boxes on the wall, right? That you press the button and the I don't know what they're called, but the little light lights up in the clinician room so that they know that somebody's there. You just have the little button. It was great. And then they put a table right in front of it so that you couldn't actually reach it, right? So there are a lot of things that you can undo. Bookcases in front of doors so that they don't open all the way is a really common one. So you've got a doorway that's the appropriate width, but then a bookcase or a desk or something is preventing full access to that doorway, right? There's lots and lots of things that we all have seen. And I'm sure most of you have seen too. So making sure that it's physically accessible. Adapting to allow for disability related needs in your counseling approach. And this one came straight out of disability services. Y'all will notice, and I try to keep it under control. This is me trying to keep it under control, that I talk quickly, especially when we have a lot of content to get through in a very limited amount of time. And often, especially those of us who are doing case management, right, who are working in voc or rehab settings, that's your entire day. Is we've got a lot of stuff to get through in a very short amount of time when you're turning over documentation and I was trying to get accommodation letters out in a sometimes 20-minute appointment from start to finish with a student. And there definitely were times where I had to recognize like, oh, I have lost my client who needs a little bit more cognitive processing time, and I have got to slow things down, and I have got to find and make the time. Right. So that is your theoretical orientation, pushing things on people that are really esoteric or complex. And they're, somebody who really just needs very literal things. Some of this is neurodivergent minds, right? Some of this is literally physical spaces, making sure that we're adapting as needed and not being so rigid that we become inaccessible by default. Having a disability affirming conceptualization obviously is going to be important, right? And addressing your ableism. And that is for all of us, because internalized ableism is a thing. And I still have to broach as a disabled clinician, especially because I'm very much in the CRIP culture, very identity oriented side of the field. If I'm working with somebody who does not align that way, I am going to have to broach, and I'm going to have to check myself and my reactions that I have to somebody who may have a different disability identity than I do, right? And there's always internalized ableism. There's always pushing yourself because you should be able to do, especially as somebody who was diagnosed late and is mostly visible based on mobility needs that are somewhat a moving target. I'm also an ambulatory wheelchair user, and I use a service dog. But I might or might not at a given time, right? And so there's always that internalized ableism, even if we have disability identity. Obviously, ARCA has our wonderful rehabilitation counseling competencies. Please know them, please use them. And beyond that, right, are you aware of disability affirming models? When I ask students, when I ask researchers, and I do this, especially to screen research that we might send out to a group space, when I ask people the models that they're using, I pretty much always hear social. Maybe I hear ecological or cultural. And I think it's really important for counseling to understand that those are counseling models, pretty specific to rehab, and also fairly outdated. Even cultural model is fairly outdated, and there's a lot more going on out there. So looking at disability studies frameworks, especially for research, are you using Discrit or something similar in your research? Because if you're using a social model of disability in your research and you're looking really broadly, I'm kind of wondering, right, if you're just not aware of the field of disability studies in which we in some ways are situated. Also, have you explored community models of disability and access, which we're going to talk about some and at least point you in the right direction. But if you're not integrating those things, then it's the same thing that we just talked about with the language, right? That people were told, here is how you talk about disability, and it's person first, and this is what is respectful, and this is the right way to do it. And really, really, frankly, right? Like, I think we all know some folks who got their training 20, 30 years ago and haven't examined it, and you can tell by some of the behaviors and the language that's used and other things like that. And just kind of pushing that forward, right? On an individual level, going out and exploring what else is happening. This is a quickly moving area, right? A lot has changed in disability studies within the last even just 5 years. So moving on.
I just think the only thing that feels other thing that feels really present for me is like speaking from an academic administration space. You know, are your faculty, your adjuncts only thinking about disability and accessibility when they get an accommodations letter from your student services office? Like, is that the only time it ever comes up? And also, if you're the person who selects the classrooms, have you actually looked at the classrooms where your students are going to be and ensured that they are, like, one of the things that irritates me the most at my last institution was none of the classrooms we used had any kind of flexible furniture, right? And that's a huge problem. So we made do, but it did create like barriers that, in my opinion, were quite unnecessary. I'll just leave it at that.
I've had one accessible desk ever. I have been in educational environments with the chair full-time in educational spaces for like 7 years, 6-7 years. And I've had one accessible desk ever. And it was for one day in one class, in that same multicultural class, actually. And then it was, we have to move to a different room because it will be easier for everyone. And I never saw the desk again. It was like a great personal loss. It really felt that way at the time.
Yeah,
all right.
there are a lot of reasons that I work telehealth. One of them being distance from my agency, but another one being my in-person office is up a flight of stairs, and that is my primary problem with my arthritis, the stairs.
Yeah, 100%. All right, so considerations for instructors briefly, and we'll kind of come back and pick up a little bit more with universal design for learning. But that's a framework that I use. I also use accessible instructional approaches. Wow, it's going to be a long day. So when we're thinking about our classroom, I feel like I shouldn't have to say this, but then I realized that I have to say this. Supporting disabled counselors and training is required by law. Like, let's just, Joe and I have this conversation frequently where it's like, why are we having this conversation? And it's like, do we need to do this? Like, at least the conversation should be, how do we do this? And sometimes we're still stuck clear back at, do we need to do this? So it's required by law, but also it increases visibility, representation, and lived experience of disability in the field. We're going to talk a little bit about kind of the retention impacts of some of this stuff in a second. But this is all going to improve services for clients because right now we've got a retention issue, a really, really serious one by the numbers. So when we're thinking about this from an instructional standpoint, at least the way that I approach it, having done some Teach to Reach and some universal design for learning stuff for a while, when being really rooted in accessible instruction, is a lot of people think about this as a big task, right? I'm going to have to do a lot of stuff. I'm going to have to convert a lot of documents and I don't really know how to do that, or I'm going to have to do this or that. This is more an opportunity to focus on some essential elements of your class, right? To really reevaluate your learning outcomes and your assessments of learning to see how you're meeting those. And when we've got an accommodation request, right, then we are going to be implementing that. And so many people have this really visceral response. And my question when I was in disability services and I was in the specialist role, which sometimes I could ask them and sometimes I couldn't, it was very much my inside voice, was, what do you lose? What do you lose by giving this student 50% extra time on the test, right? Like, why do you have to call me and scream at me as the student member of the team about this accommodation, which really is sometimes how visceral the reactions to this can be. But I would push people to go one step forward and to consider proactive accessibility of materials and activities, right? So that we're not having to do accommodations, that we're providing this universally designed environment, which we'll talk about a little bit more in frameworks. And what we really talked about on the UDL team a lot was that this can be overwhelming. These are resources that I have, and it sounds like we also may be developing for ARCA. Thanks, Daniel, for helping us head that up. But I also have them. So if you want information on this, let me know, because again, this is its whole own presentation. But we really stress do one thing. Just do one thing. Pick something to do in your course each semester, because then you're cutting down what you need to do if you do get a request and you have to go in and do it. But you're also consistently engaging in that reevaluation of your course and your materials. All right.
So in terms of disability etiquette, interpersonal practices, we've talked about a lot of this already. So language, being really intentional about what language you're using in what spaces and why. Are you using this language in this space because it's common practice in this space? Are you using this language in this space because this is what has been requested of you for this space? Are you using this language in this space because it's what's most comfortable for you personally? And is that something to potentially unpack? So just being really intentional and aware of what language you're using, why you're using that language, what that looks like for you in that space. Asking questions rather than making assumptions is really important. Not all disability is being visible. When I was in undergrad, I was experiencing a lot of problems with my arthritis, and my research lab for my thesis was up on the 3rd floor of a building without an elevator. And then my next class after gathering research was across campus. So I would frequently use campus security, had a golf cart that they would use to escort students. And I had one campus security person come up to me, look at me and say, "Oh, this is for folks who have injuries," and drove away. And so I called my friend who was head of campus security and said, "Hey, I need a ride over to Epley for my music classes because one of your campus security officers just drove away from me because apparently I'm not disabled enough." So we had a lot of conversations around that, and it's things like that. They could have asked a question. "Hey, are you having limitations being able to walk across campus?" Rather than just looking at me and deciding that, "Oh, because you're not wearing your knee brace," or, "Oh, because you're not using your cane, you're not disabled enough to need our help." Getting to know the person as opposed to only focusing in on the disability. While a lot of us do use disability first identity, first language, we are also whole people with lots of experiences outside of our disability and within our disabilities. So it's really important to not only focus on the disability, but getting to know us as people, getting to know what those experiences are. And some of this will fall into universal design as well, in terms of acknowledging that all people as humans can benefit from accessible spaces, not just because of certain access limitations that we may have. And this also kind of falls into that, as maintaining a low trigger environment. There are some folks who have lighting or noise sensitivities. I personally really like my telehealth office because I have a dimmer switch on my light, as opposed to my in-person office that is just super bright fluorescence, or like a couple of lamps that don't really provide a whole lot of light, and not a whole lot in between outside of like adjusting my blinds on my big window. And so I am frequently throughout the day messing around with the lighting situation in my in-person office. Where my telehealth office, I just have my nice little dimmer switch that can go up and down. And that's something that, within maintaining a low trigger environment, is something that I'm very intentional about with my clients, because I know I experience migraines, and migraines are awful in terms of having a lot happening around you. And it just makes for better educational and clinical spaces if you aren't being distracted by the lighting, the noise, the everything happening around you, right? Respect for assistive technology, acknowledging that folks may be needing to use different types of tech for different purposes. I had professors who were very staunchly against folks having phones in their classes and having phones out. It wasn't until I explained to a professor that I would dictate into a notes app in my phone because I didn't yet have Dragon for dictation into my laptop and have that software available to me. I would just use my text dictation into my phone to take notes because typing is super awful for my hands and I absolutely hate it. Handwriting is awful for my hands. And so having those conversations rather than making an assumption of, oh, because you're on your phone, you're not paying attention in class. Right?
Also not interfering with assistive tech and not commenting on assistive tech, and service dogs count. It is just as rude for you to tell me how cute my service dog is, and you know you can't pet him, but he's so cute, as it is to ask me questions about my wheelchair.
Mm-hmm. Yeah. Or to state that you can't make accommodations in certain spaces for different types of assistive tech. And not pre-planning that, oh, hey, we're going to be having a residency, a conference, a whatever, and not going into that experience, preparing ahead as though there are going to be folks with different access needs. If you're going to be having a conference, you're going to be sharing space with other people. You are more likely than not going to have disabled folks in that space. Go into those spaces with that expectation already in your head so that you're not going in and scrambling at the last minute to make all of the access changes required to ensure that folks can utilize the space that they need. Lynn, Joe, did either of you want to talk about microaggressions?
No, I think that there's a whole other presentation in this series too on microaggressions, and I'll leave it to them because it's their area of research, but do inform yourself.
Yeah.
All right, so I think that we have given a fair number of examples, and if you haven't read Academic Ableism, you're going to go read Academic Ableism. And we've got one slide as just an example on implications, because I can say academic job search was horrific for me. And I absolutely understand why we are where we are here. So image description, this is a old brick building with big marble columns. It's on Penn State's campus. This is Old Main. This is the administrative building. And there is a very prominent set of stairs at the front of the building. The only other access to this building is down about a block of cobblestones that are poorly maintained and through a back door. And this is where I went for big important university meetings every once in a while when I was at disability services. Dolmage would argue that our physical settings on campus are reflective of the campus biases. This is academic ableism in photographic form. National Center for College Students with Disabilities, they only give an estimate because nobody's really tracking this. But they estimate that perhaps something like 4% of faculty members have disabilities. I think that from a couple of things I've seen, Harvard and some other places, that might have gone up by a couple of percents post-COVID, but we're still pretty low. We already gave, something between 25 to 30%. Like, it really depends on your stats and how they're actually defining disability in their stats. But we've got a fairly large percentage of the population with disabilities. It doesn't line up, right? And we see this go down. So we see with undergraduate students, it's about a quarter. With graduate students, that goes down to about 11%. And then faculty, we've got these estimates somewhere between like 2 and 6%. So to me, that really speaks to an environment that's causing people to self-select out. There clearly is some kind of barrier to retention that's going on. All right. I'm going to frame just a few things here. Guys, pop in as needed. And then we'll get to some really advocacy-oriented stuff for the last bit and give some more examples and suggestions. So we've got some different approaches that we could use to understand access and accessibility. We already gave the definition of accessibility that we like to use, right? And then sometimes when we're talking about accessibility, we're just talking about like the bare minimum legal definition of accessibility under the ADA, right? Doorways are 34, 36 inches. These, you know, these other pieces that we all know and love from the checklist for existing facilities. So that's the accessibility piece. And that's just about the environment, whether people can get into the environment or not, right? And that sounds very physical. That can also be brain and mental and stigma, right? But whether the space is accessible to get into. Accommodations are things where we alter programming or something that we are providing based on a request, right? A sign language interpreter is an accommodation. Is I wish, but most places are not going to have one de facto already there in the environment. We also have classroom accommodations. That's where a lot of us know this from if we're in education, right? Where this is a request that's made and then we change something that we're doing. Universal design and universal design for learning, we already sort of alluded to a little bit, but universal design is an architectural approach. And what universal design says is that products, and this is very broad, this can be settings, whatever, but products should be designed to be usable by everyone without adaptation, specialized design or accommodations. So there's some principles under UD, equitable use, flexibility in use, perceptible information, multiple means of engagement. And this gets transferred over into universal design for learning, which is its own set of principles that you can apply to your classroom. Again, if you're not familiar with UDL, please go look at UDL because we're not literally going to teach it because we can't, because I've done 5-hour workshops on UDL. But the key really to UD and to UDL is that we're encouraging creative solutions to problems that partner collaboratively with end users, but are also proactive in their implementation. So we're getting that information, we're finding out what works, and then we're putting it on the forward end so that we don't need to make as many accommodations later, because hopefully the design or our classroom, our curriculum, right, are already accessible when people get there and usable beyond accessible. And that speaks to disability equity. Yay, I set myself up. But I put disability equity on this slide because it's a constant struggle. And in UD spaces, we had this problem all the time on the UDL team where people immediately go to a curb cut model of, oh, and this benefits everybody, subtext being the people who matter, right? How many people have heard curb cuts also help moms with strollers or people on bikes or people delivering things? Oh, the people who matter, it helps them too. And that can be what happens. We've already mentioned, right, what's at the bottom, which is that access sometimes gets co-opted, or DEI spaces may also literally not be accessible. This has happened to me and my colleagues more than once, where we're asked to a general kind of DEI thing and then find out it's not accessible and we're sitting in front of a stage that everybody else was on to talk because there's no ramp, right? So these spaces sometimes aren't accessible, and disability gets dropped really, really quickly. So I've been using disability equity to really center disability. I'm learning something from the person first crowd and saying, if I put disability first, people are less likely to drop it. I don't know. I'm going to give it a go. So what we're really talking about then is proactive barrier reduction, right? And that we're seeing potential barriers, we're examining potential barriers, we're moving through a space, or we're engaging with something and trying to put ourselves in the shoes and see what could go wrong and fix it before people get there. But the other thing besides proactive that barrier reduction kind of centers is that this is reduction. Joe and I in our ACEs have talked a lot about barrier reduction, not barrier elimination. We don't think that we're going to get it right 100% of the time, right? And people have conflicting access needs, and there are things that happen that you could not possibly predict. An air wall goes out at a conference, and all of a sudden you can hear the room next to you better than the room that you're in, and it broke a week before the conference with a 2-month timeline to fix it, right? There's nothing that you can do in that scenario. You got to work with what you have. We might inherit bad sites. We've got bad architecture in our universities, right? There are barriers that we aren't going to be able to get around. So reducing barriers where we can, and then having the humility to work with people when they encounter barriers in ways that are still affirming and still validating and not getting defensive and shutting people down, which all brings us into disability justice and community frameworks, unless there's something I missed, guys. Okay. So this is a community definition of ableism. We've talked about ableism here and there, but I did want to put this in the community slides. This was documented by Talia Lewis a couple years ago, but it's very much part of a community brainstorming process. So ableism is a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. The systemic oppression that leads to people and society determining people's value based on their culture, age, language, appearance, religion, birth or living place, health or wellness, and or the ability to satisfactorily reproduce, excel, and behave. You do not have to be disabled to experience ableism. So this is the work that's happening in community. And if I give you an academic definition of ableism, it's going to be ableism is favor of the able-bodied over disabled people. Like that's literally going to be all it is. So I put this here partially to point you at disability justice community as we move into some principles from the disability justice community, because the conversations that are happening in community are much, much different than what is happening if you are not in it. So when we're talking about disability justice, and this is broken down in Skin, Tooth, and Bone. If you have not read Skin, Tooth, and Bone, please get it. It is available on the collective's site, and you can get a PDF of it for like $3 or $4. Please just go get it and support them. So again, this is a community collective that has set this framework forward. A disability justice framework understands that all bodies are unique and essential. All bodies have strengths and needs that must be met. We are powerful, not despite the complexities of our bodies, but because of them. All bodies are confined by ability, race, gender, sexuality, class, nation, state, religion, and more, and we cannot separate them. These are the positions from which we struggle. We are in a global system that is incompatible with life. So I said I was radical. Community, there are parts of community and disability justice that put me to shame. I'm like, man, I've been in academia too long. So engage with the culture, really, but they've also published disability justice principles. If you are not familiar with the disability justice principles, please, please go and engage with them, because if you are doing advocacy work and you are not centering community values, which is what this is an attempt to really collect and to explain, you're not really doing advocacy work, because we're about to talk about that, right? And you got to center voices that are involved. And one of the very first principles is leadership of the most impacted. So if you were doing disability-oriented work and you are not doing it with disabled people actively involved, it's not disability justice. There's lots and lots there, and I'd be happy to unpack this with anybody, but I want to get us into the advocacy stuff. Good, move on, guys. All right. I will just make one last note that there are some other community models emerging. Obviously, there's identity-based models, Lund, Forber, Pratt, right? There's some people doing work in that area. I've seen a few things that get labeled like affirming model. It's very squishy still. It's not very empirically rooted yet. Community is talking about things like access intimacy, which is the connection that we feel with other people who have experienced similar barriers and oppression, as well as forced intimacy, which is what happens when we have to rely on able-bodied people, what Leo was talking about with needing to phone a Joe, right? Or that thing where you have to go ask somebody. That's forced intimacy. That's bad. Access intimacy is what we feel with one another when we say, crap, this place is really inaccessible. Do you need help? I don't know if I can help. But like, let's at least go figure it out together and we'll get stuck in an inaccessible bathroom together. Good. Right. And that's what we're kind of dealing with. It's happened. I only use things that have happened. Stuck in basements, stuck in bathrooms. Joe, you were there when I got stuck in the bathroom at the conference and needed rescued. So there are some significant challenges to actually having empirically based community grounded models because of all of the bias and the separation that we've been talking about, right? Because researchers have not been working with community. There's not been a lot of community-based research that's happened yet. And so we're always in this struggle when those of us who write and who research in this area, right, are always in this struggle where it's like, I have a blog that I can cite to talk about access intimacy, but there's not grounded theory on this. There's not something that a journal editor is going to want as a citation for this. So how do I talk about this really important thing that is a value within community? And then the research ends up not being representative. And then what we teach our students ends up not being timely and up to date. So tying that all together. All right, advocacy.
All right, folks. So I want to specifically highlight something that we've already touched on, which is this idea of proactive barrier reduction, because I will tell you that's where most of my active allyship has come into action, because this is a practice, and I would even say how I experience it is as an embodiment of a set of, honestly, it's part of my personal ethic to be involved in this, right? So it's something that you engage in, not just not identify as, right? It's certainly part of that, but it's not just that. So it's making sure that you are existing in a solidarity space with people from the community leading, right? You're not with the exception of when you might be directly asked to do so, you are not stepping in and speaking for or on behalf of, except in cases where maybe you're the only person in the room who has that knowledge and that needs to be brought into the space. So you are understanding your position in the struggle and the fight and engaging in the appropriate way, right? And that starts with listening, and listening and listening and listening, and asking questions where appropriate in an appropriate manner. I also like to remind you that if you are engaged in this practice effectively, you may be in a place to where you might have to ask uncomfortable questions, right? But if you have the level of intimacy that I think comes with engaging in allyship in a proper way, it is better that you ask those questions and learn about what the person might need, learn what their what preferences they might have as well, so that you are doing your job in support effectively. Focusing on the impact, especially when the impact is harm, and how to move forward from that. I got into this work, like I said, by a happy mistake, as a conference coordinator, where I thought I had taken into account everything, and I hadn't totally missed the mark, but there were things that I had not thought of. And to share what it was is that I knew that there was an accessible route to the building. However, what I didn't think about the fact is that it was extremely inconvenient. And also, if you weren't a student at that university, you would have absolutely no way of knowing how to get there. And then I also didn't think about the fact that there was a door that was going to lock in that route and someone would get stuck, that someone being Lynn.
Joe locked me in an alley.
Again,
Joe abandoned me and locked me in an alley.
I did. I did. But so that's what I'm talking about, and how
we became friends.
It is.
We handled it really well after the fact, right? And we debriefed it and we repaired.
Yes, exactly. So that's what it takes. Also, there was.
I had
to. What's that, Leo?
When you make mistakes.
Yes. Right.
We're not going to get it right 100% of the time.
No, it's impossible. And so meeting that person directly, explaining the situation, saying, hey, this is what I'm hearing. Is there anything that you need? And I'm speaking specifically in the conference space, but I'm also thinking about from the barrier reduction space. Lynn and I at several conferences walk around at 7 o'clock in the morning and make sure all the rooms are not inaccessible, because they will be. And so we know we
reset them later.
Yes.
When they get set up again wrong.
Yeah. And it is, again, the conference staff's intent is to set the room the way they were told to set it, and having, likely no access training at all. And so we go around and change those kinds of things. And engaging in that process is an effort at allyship, but I am also literally the person who has to move the furniture. So there's the physical piece to it, right? You're leaning into that discomfort, and again, setting aside your any shame you might have about having made the mistake, right? Because that's how you're going to learn, and integrating those new perspectives into how you operate. One of the most powerful conversations I have ever had in this work was Lynn just saying to me, she was like, just walk around and think about how unnecessary all these stairs are. And now there are things that I can't unsee. And so that's what I'm talking about with this integration piece, is now this is a part of my core being of how I work, right? In all of the spaces that I'm in, I'm looking for the things that are going to cause issues and how can I proactively address them. Making sure that I'm modeling this inclusive language and offering growth-focused and teachable feedback to my peers and colleagues. And then using that acknowledge, apologize, and move on, because all you can do is do it better the next time. I mean, you could also, be lazy and not do it better the next time and not learn anything from the situation. But our hope is don't do that. Yeah. So that's all. Just do that.
So thank you to our token ally. I appreciate you. So advocacy, we've been talking about off and on throughout this whole presentation. There are a lot of reasons that we need to advocate. We have communities under attack, including our access to services. Civil and human rights equity is lacking. We've talked about marriage equity, marriage equality in disability spaces, and how folks can lose access to things like Social Security disability income if they choose to get married, because their spouse's income would put them over the limit to receive disability income through Social Security. There are legislative concerns, including service and funding restructuring. So when we think about things like DEI legislation, focus legislation, that can impact the ways that we implement some of these things in our educational spaces and talk about some of these things in our educational spaces. It can impact the funding for different services. So think about things like vocational rehab services and the funding that our voc rehab programs are getting and the staffing that our voc rehab programs have. I know that our vocational rehab wait lists are insane and sometimes impossible to get through. And a lot of that comes down to funding. A lot of that comes down to the resources that they have, and a lot of that is legislated. We also, as counselors, have an ethical responsibility to advocate. Within the American Counseling Association Code of Ethics, they state that when appropriate, counselors advocate at individual, group, institutional, and societal levels to address potential barriers and obstacles that inhibit access and/or growth and development of clients. And we are very fortunate that the ACA provides us with some guidance on how we advocate. So Lynn, if I can get my next slide. So on this slide, there is an image outlining a model of the ACA advocacy competencies. So this is a figure showing levels of advocacy as outlined by the American Counseling Association advocacy competencies. On the x-axis are micro level through macro level advocacy frameworks, including the individual, community, and public domains. And on the y-axis determines whether we are acting with or acting on behalf of individuals, communities, or the public. So I have heard some feedback on that particular graphic that it can be a little bit confusing about how to apply it. So we've made a slide talking about
this was a great brainstorming session for us too. Like this was fun.
This was really fun.
Sad, but fun.
I basically sat down and walked Lynn and Joe through how I typically teach on advocacy, because I typically teach on LGBTQIA+ advocacy. So I did a little speed run of what I typically do, and then we applied it to the disability space, because these competencies cross apply in a lot of different arenas. So when thinking about individual level advocacy, are we connecting with job training, employers, vocational assistants, getting to know where those services are in our areas and being able to directly connect students and clients with folks who are in our areas on the ground doing that work? How are we empowering clients and students and their autonomy? And are we using affirming frameworks? Are we using affirming language? Is our paperwork accessible? Are our office spaces accessible? Is our parking lot accessible? Are we looking at these things holistically? And what are we doing to ensure that this access is being met? In terms of broaching and modeling, you've seen Lynn and I do this a couple of times throughout the presentation, talking about our own lived experiences with disability and how that has impacted us. And also modeling. So when we've had images within the presentation, we've verbally read through the image descriptions for folks who may be blind or otherwise vision impaired and may have a hard time interpreting some of the graphics or seeing the graphics altogether. So being able to model some of those things for clients, for colleagues, modeling language, modeling use of assistive tech or some of these other strategies. When we look into community, are we working with conference coordinators? Do we have conference coordinators who are looking at accessibility specifically? And if not, do we have the space and access to build those committees or reach out to folks who are doing that work in other spaces and engaging in that advocacy work within the system? Educating the community and working with community-based services and integrating within schools. Lynn, did you want to talk a little bit about affinity spaces?
Yeah, let's just at the end. So let's hit public level quick.
Okay. Public level, looking at the legislation that's impacting these communities, working with national organizations like the ACLU, disability rights and education, criminal justice, societal integration, autonomy are really big within ACLU's frameworks surrounding disability. And so working with them to see what some of those things look like on that public level. Again, looking at legislation, marriage equality, reproductive rights. These are all things that we can look into on the public level and advocate and see what these things look like and how they're impacting our communities.
And I'll just wrap this up with a lot of what I know we all have been doing is really building community. And you all are part of that now. Thank you for showing up today. But particularly if you have a held disability identity, I saw my colleague Helen Starkweather is also on this call. She's my co-chair in the disability justice and accessibility community, which is an affinity space within counseling and within counselor ed, and a place where disabled counselors, counselor educators, both of those in training are all connecting. And that I think is going to be one of our keys, especially in the short term, to fixing the retention problem, right? Just getting people connected and getting people resourced and being able to operate in community. We've also got some allyship stuff that I think we're going to be working on. So you're welcome to get in touch with any of us with any questions, because I know that we're right up at time and I'm about to hand it back over to Daniel to close us out. But certainly if you're interested in allyship or in an affinity space, also get in touch with one of us and we'll get you kind of directed to the right person for that. Daniel, all yours.
Wonderful. Well, thank you so very much to all three of you for just a truly wonderful presentation, so timely and relevant and just so very much needed. So thank you all. We did have a request in the chat box if it'd be possible to share the PowerPoint afterwards, if that would be okay with all of you.
Yeah, and I don't know what the best way to distribute that is, but certainly I have a copy saved locally. I can send that to anybody if you want to email me. I'm affiliated with Mercer University. I'm very easy to find. You're very welcome.
Great. And so people can contact Dr. Pierce directly, or Dr. Pierce, if you would also be able to send that to us, then myself, and we can send that to all the participants afterwards as well. So
I'm also putting my email in the chat for those who are able to view that.
perfect. So
I also just want to note that Helen has also put her email in the chat regarding
For the affinity
AAC.
space. Mhm.
So for folks who want
Thanks,
to reach
Helen.
the affinity space, Helen has put their contact information in the chat. We so appreciate that, Helen.
thank you, Helen. And at this time, of course, we would just like to provide our sincerest gratitude and appreciation to Dr. Pierce, Dr. Charette, and soon to be Dr. Valeo for this wonderful and meaningful presentation on accessibility advocacy and counseling spaces, barrier reduction, and community building. Dr. Pierce, Dr. Charette, and Dr. soon to be Valeo, we are most grateful for you all taking the time to share with us today. For those in attendance, we also appreciate you joining us today, and we would like to invite you to our next ARCA webinar as part of our month-long June 2024 webinar series, which is scheduled for today, Friday, June 28th, 2024, from 12 p.m. Eastern to 1:30 p.m. Eastern Time, titled Teaching Disability as Diversity. For those who will be joining us, we will be placing you in the Zoom waiting room until closer to the top of the hour, and we hope that you'll consider joining us. On behalf of the American Rehabilitation Counseling Association, once more, we'd like to thank our wonderful presenters, and we thank each and all of you for joining us today, and we wish everybody a wonderful weekend ahead. Thank you all so much.